Hi, welcome back to the Pharmapreneur Academy. This is lesson 11. Today we are going to dig into pay for performance in depth, how to use consultants to help you achieve your quality metrics. This is updated for 2020, so we want to give you the most relevant information to be able to talk about quality measures and how MACRA impacts ambulatory care and health system practices. So, show of hands, how many of you are already regularly discussing mutual patients with local collaborative providers? So I hope you are. Reimbursement models, as we know, across the board, we've heard this, but what does it actually mean? They're shifting from volume-based fee-for-service to value-based payment systems. What does that mean? So today we're going to dig in to what it means to be a value-based payment system and what those changes look like. So we've got to start back with MACRA. That is the Medicare Access and CHIP Reauthorization Act of 2015, what created what we now know as the Quality Payment Program. The Quality Payment Program is broken down into two separate tracks. The first track is the Merit-Based Incentive Payment System Program, and the second track is the Advanced Alternative Payment System Program. So now we're going to focus specifically on the MIPS clinic in the Merit-Based Incentive Payment Systems, so MIPS clinics, and then towards the end we'll go back and we'll talk about advanced APMs and how they are a little bit different. So prior to MACRA's creation in 2015, Medicare reporting looked like this. There was a what's called PQRS program, there was a value-based modifier program, and there was an EHR incentive program. MIPS combined all three of those programs into a new model. The MIPS model measures providers' performance in 4 specific weighted care categories. Those weights change each year, so I'll give you the most updated weights for 2020, but keep in mind those do change every year. So the quality category replaces the PQRS. The Advancing Care Information category changes what was known as the Meaningful Use, or EHR incentive program. The Improvement Activities is a brand new category that was created in MACRA, and one of my favorite categories because it mentions pharmacists specifically. And then the Cost Resource Use category, which replaces the Value-Based Modifier program. So your MIPS composite performance score is based on your total 4 categories and the weights of each. So for 2020, again I mentioned the weights change every year, but for 2020, quality is at 40%, advancing care information 25%, improvement activities 15%, and cost resource use 20%. So we're going to break each of those down specifically into what are the ways that we can help providers to improve their performance in each of those categories. First, let's talk about what are some exclusions. So who are the providers that are excluded from submitting data for MIPS? So those participating in an APM are not subject to MIPS. We'll talk more about APM here in a little bit. Also, if you are in a low volume threshold, which includes a combination of not very many Medicare patients being served, Medicare lives, or low billing volume, then as the practice grows, they can actually go from being excluded from submitting data to actually required to submit data as the practice grows. That's reevaluated annually. And then providers who enroll in Medicare for the first time during their performance year are exempt until the subsequent performance year. So again, here is the 2020 update for what the 4 weighted categories of MIPS looks like. As you can see, quality is the most heavily weighted. There are 500 million reasons set aside to get this pay for performance thing right. So just to give you an example of a quality outcomes example, $50 million service line for an ambulatory care practice, you could get up to a plus or minus 9% bonus or penalty opportunity for that clinic. So that's $4.5 million in bonus incentive payments or penalty payments. So lots and lots of money at stake here. They are wanting to change these for 2018. so you report in 2018, you report, and your payment adjustment will be reported in the 2 years after. So whatever you report in 2018 will what you see your payments being adjusted by in 2020. So 2020 would be the first year that it's really gone into effect. Of course, in 2020, we're dealing with the coronavirus outbreak. So CMS has actually loosened up that requirement for data reporting for 2020. So we may not see this increase up to 9% by the year 2022, but it is definitely coming. So let's break down each of these 4 weighted categories and talk about specific things that we can do to improve providers' performance. So let's talk first about quality. So the first and most heavily weighted quality or category that we're going to talk about is quality. So again, this is one of the holdovers from the PQRS, Physician Quality Reporting System. It used to be 9 measures in the PQRS system. Now what they have done is they have had the physician's practice choose 6 quality measures from over 270 subcategories and things to choose from. One of those measures must be related to some kind of outcome. One of those measures must be what's called a cross-cutting measure, which means it's applicable to all provider specialties. And then the other 4 can be whatever the clinic wishes to choose. So if you hear me talking about, always ask, what quality measures are you reporting on? What benchmarks are you focusing on? What are your goals this year? This is what I'm talking about, the 6 quality measures that the clinic chose to report data on to Medicare. There's 6 primary intervention categories that pharmacists can help providers with to improve their performance scores: patient safety, person and caregiver-centered experiences and outcomes, communication and care coordination, effective clinical care, community and population health, and efficiency and cost reduction. So let's focus in on each of those 6 intervention categories. So first, let's start with patient safety. So this could look like a partnering with a collaborative provider to offer a comprehensive medication review or med reconciliation post transitions of care. We talk more about transitional care management opportunities in Lesson 8. So you can review that, thinking about how you could be the first person, that first touch point, which can be done non-face-to-face, post-discharge for that patient, and help the provider's office capture the documentation billing criteria required to build that code. You can counsel patients face-to-face on new medications, post-discharge or otherwise, and also document that in a care plan and send that to collaborative providers. So again, you can do transitional care management, especially the first non-face-to-face touch point, as a remote or off-site consultant pharmacist. So I'm really excited about that opportunity. Do you remember what was the average reimbursement amounts for transitional care management? If you look back at Lesson 8, it is pretty generous, around $175. So the second quality intervention that pharmacists can lead is the person and caregiver-centered experience and outcomes. This would just be including family members and supportive caregivers in the patient's care, and gathering up patient-reported experiences that reflect involvement of their family members and understanding of their health care or their health condition and how they can help effectively manage it, including lifestyle modifications, things like smoking cessation, things like nutrition and exercise, all of these types of things. The third is communication and care coordination opportunities. One of my favorite one is, of course, setting up a collaborative practice agreement to help with documentation of these patient care activities, and also using chronic care and transitional care management codes for off-site or remote chronic care management of the patients. You would document the clinical and preventative services that are being offered and notify prescribers of any changes in the care plans and updates to the care plans, so that their records are up to date. Each time you have an intervention with a patient, at the very least, you should send over an updated medication and fill record to the provider's office at least quarterly to make sure that you are sharing that information about the most up-to-date data. Effective clinical care opportunities, this can be using things like comprehensive medication reviews or MTMs or chronic care management, even health risk assessments like we talked about in lesson 10. Health risk assessments, doing those on behalf of the provider prior to an annual wellness visit to make sure that appropriate prescribing and monitoring parameters are being met, and you can make recommendations for any evidence-based guidelines that you see as a good fit for the patient. Community and population health activities, especially in 2020 as we're seeing the rise of the coronavirus, I believe that community pharmacies are going to play an even bigger role in providing point-of-care testing and screening services as we're seeing the coronavirus outbreak really overwhelm and overburden our medical system. We are also seeing treatment of other chronic condition or other acute conditions like influenza or strep be better managed in the community or home-based setting by community pharmacists. So being able to screen for and refer patients to higher levels, advanced levels of care for either acute or chronic conditions is definitely an opportunity that I see for helping providers increase their performance in the future. Efficiency and cost reduction. So this would be enrolling patients in adherence programs, considering establishing some kind of transitions of care program, at the very least help focus and manage readmission rates for the patients and your health systems. So those are the 6 pharmacist-led quality interventions that I see opportunities for us to leverage in order to help improve provider performance. Now let's go to the next weighted category in the merit-based incentive payment system, which is advancing care information. So think of this one as the technology one. So advancing care information replaced meaningful use. So that was the emphasis on the EHR implementation. It emphasizes technology to streamline patient care processes. This is the reason that every time you go to the hospital or the doctor's office, they ask you for your email address. Because with the certified EHR technology, they are receiving performance incentives for using electronic prescribing and electronic access to patient medical records. Pharmacists are increasingly able to create e-care plans depending on your pharmacy's dispensing system that can be shared with other providers to improve patient care. And so it's definitely something that we should be leveraging as much as we can. The main things to think about in advancing care information is protecting EPHI and giving the patient access to the EHR. You're also going to see more and more use of electronic prescribing and communication via secure e-messages back and forth. They are trying to promote interoperability and sharing of information on the health information exchange and really making care coordination efforts much, much easier. So think of advancing care as the technology category. Now we're going to talk about improvement activities category. So improvement activities are really exciting. There are 90 new improvement activities defined for MIPS, and the major subcategories of each of these are expanding practice access, population management, care coordination, beneficiary engagement, patient safety and practice assessment, achieving health equity, integrating behavioral and mental health, and emergency response and preparedness. So remember, this is the new category that was created by MACRA. The 3 main opportunities I see for pharmacist impact, and we'll dig into each of these, is implementation of medication management practice improvements, proactively managing chronic and preventative care for patients, and communication and care coordination. So first, let's talk about implementation of medication management practice improvements. This is the only page in the entire document that mentions pharmacists at all in the MACRA legislation, and the recommendation is integrating a pharmacist into the care team. As a care team member, they would be expected to conduct periodic and structured medication reviews, at the very least quarterly. They would reconcile and coordinate medications, especially during transitions of care, help identify and resolve DUR reviews, and adjust strengths, dosage forms, or therapeutic substitutions as needed. So really focusing on optimizing therapy, cost savings, managing transitions of care, and reducing readmissions. So the second opportunity for pharmacist impact would to be managing chronic and preventative care for patients. We talked about this a lot when we went through Lesson 7, Lesson 8, and Lesson 10. So individualized care plans, patient education, enrolling patients in community services like medication synchronization programs in the community pharmacy, MedPAC type programs in the community pharmacy, screening for comorbid conditions, offering annual wellness visits, offering remote chronic management for patients, and performing routine medication reconciliations for our patients is all so important for ongoing care plan management. And then the third pharmacist impactable improvement opportunity is in communication and care coordination. So document everything we do, whether you're in a community pharmacy setting or you're a pharmacist clinician already in an ambulatory care setting. Document pharmacist interventions and document the patient care activities if you're offering services like remote chronic management or transitional care management or even remote patient monitoring services. Always be on the lookout for preventative services and be thinking about how the services you're recommending aligns with the quality metrics being chosen by this specific practice. Always make sure that you are communicating back with the prescriber and their record is the most up to date. At the very least, send an updated medication list and fill history to the provider's office on a quarterly basis. And then the fourth weighted category of MIPS that we're going to talk about today is cost. The fourth weighted category that we're going to talk about today is cost and resource use. So this is increased to 20% for 2020. It was calculated in 2017, but it was not used to determine payment adjustment until 2018. It includes automatic submission of data to Medicare throughout the year, and it encourages healthcare professionals to help beneficiaries understand their benefits and make medical decisions accordingly. It is used to compare resources that were used by the provider's office to treat similar care episodes and compare clinical condition groups across practices. Some of the key changes were some 40 episode-specific measures to address specialty concerns and increasing the weight in 2020 from 15% to 20% in 2020. So pop quiz, in which MIPS category are pharmacists specifically mentioned? If you said improvement activities, you are absolutely right. So remember, when we first talked about the quality payment program that was created by MACRA, it was broken down into two tracks. First was the MIPS track, the Merit-Based Incentive Payment System, which has 4 weighted categories: the quality, the improvement activities, the advancing care information, and the cost resource use category. Now we are going to focus on the second track, the Advanced Alternative Payment Model System. So Advanced Alternative Payment Models, what we'll call APMs for short, is a payment approach that rewards providers for delivering high quality and cost-efficient care. Advanced APMs are a subset of APMs that let practices earn more rewards in exchange for taking on more risk. So it's based on patient outcomes, and there's an opportunity for a 5% incentive payment by going further and improving patient care and taking on risk. CMS expects about 10 APMs to qualify for the MIPS APM scoring standard for 2020, which would include these. Some of these are also referred to as ACOs. So if you'll notice, some of the shared savings programs on there are ACOs. Here in Arkansas, we have access to the Comprehensive Primary Plus clinic. That is a specific clinic program that's only available in certain regions of the U.S. So some differences, as we mentioned, MIPS clinics get to choose their 6 measures that they're reporting on. An APM clinic is assigned 15 measures. And participation requirements definitely depend on the program. So CPC Plus may have different measures than a shared savings program. The quality indicators may or may not be medication related and may be objectively measured using technology like remote patient monitoring. Medication adherence is something that they may look at. Medication persistence, which is the active continuing treatment for the prescribed duration. And also adverse events are some big medication related opportunities. The net financial gain for participating in an advanced APM can be greater than 5% if the APM realizes their shared savings, or if their shared losses are realized, the net gain can be lower than 5%. Since a MIPS or APM score travels with the physician, if the clinician earns the 5% bonus incentive for a given performance year because they participated in a successful pay-for-performance model, and then they move to a new organization the following year, that new organization actually inherits that 5% incentive payment. So the clinician's position may be enhanced with respect to recruitment and contracting with provider organizations if they have good performance and incentives associated with there. The drawback, of course, the financial margin, which is the revenue minus the program cost of APM participation, is somewhat unknown and very hard to measure. And APMs, such as the Medicare Shared Savings programs, have yet to earn incentives, often due to continuing performance benchmarks to be changed and refined by payers. The APMs are compared to national benchmarks of quality and cost performance, and it creates a competitive playing field where not all players will win. So not all clinics will be successful because they're being compared nationally to other benchmarks. So there is a net zero, so to speak, kind of benchmark. They are also required to publicly publish quality and cost performance of their entity, which can have reputational impact on the clinicians as well. Some common pharmacist interventions and recommendations you guys have heard me talk about time and time again include MedRec, medication education, lab recommendations, immunization, medication compliance, deprescribing, ends of therapy, discontinuation of therapy, alternative therapy, optimization of medication regimens, drug interaction identification, drug gene interaction identification. Lots of pharmacists interested in pharmacogenomic testing, and also identifying if a dose is being pushed too high or too low based on something like inappropriate technique or non-adherence. Some of the benchmarks I wanted to include some ACO measures that can be affected by pharmacist interventions. Of course, looking at patients from a risk stratified standpoint, who are the most impactable patients by pharmacy, and focusing on making referrals for those high-risk patients, a standard of care can really improve the performance metrics of the clinic. So screenings for fall risk, immunizations, monitoring heart failure, weight management screening, tobacco and depression screening, colorectal, cancer screenings, A1C, blood pressure screenings, some of these things that really fall quite well into the pharmacist's wheelhouse and guidelines that we are very used to understanding and focusing our efforts around, like the ACE inhibitor, ARB therapy with patients with coronary artery disease or diabetes. So those are some of the ACO measure sets. So those all had to do with Medicare. The difference in HEDIS measures is HEDIS measures apply to private payers. So up until now we were talking about MACRA, which impacted CMS primarily Medicare Medicare payers and beneficiaries. Now we're talking about HEDIS measures that impact private employers and private insurers. So these are quality measures used for commercial health plans and sometimes Medicare Advantage plans as well. More than 90% of America's commercial health plans use these measures. They specifically define about 94 measures across 7 different domains of care, and they allow plans to compare their performance for outcomes, cost, resource use, and some of the same things we talked about when we talked about the quality weighted categories. So many of the HEDIS gaps can be closed by a pharmacist during an annual wellness visit, during an MTM pharmacotherapy consult, like we talk about in Lesson 8. So to give you an idea, some medication-related HEDIS measures specifically, high-risk medications in the elderly, antidepressant medication management, osteoporosis screening and management, control of hypertension, transitions of care, statin therapy for patients with diabetes, pneumococcal vaccine. I mean, these are all things that pharmacists can do and actually excel at when we look at coordinating care for our patients. So I want to talk a little bit about marketing these consultant programs to physician groups. I think it's very important, and the reason we really focus in Lesson 11 on MACRA and MIPS and advanced APMs and HEDIS measures is because it is such a poorly understood program. We all hear fee for payment and pay for performance and value-based, and they have no meaning. So this is an attempt to attribute meaning to what it means to align your services with the quality payment program. So why would a clinic want to hire a consultant to run chronic care management or to focus and be a care coordinator focusing on their quality payment program benchmarks? It allows the providers to see more new and complex patients. A lot of times for some of these services like chronic care management, remote patient monitoring, and transitional care management, you can do so under the general supervision of a physician, which means essentially outsourcing some of the care management. We can also show improvement in quality measures like chronic care management can lead to better adherence and better patient outcomes and thus more revenue. Plus, it can lead to, with the better outcomes and with the quality benchmarks, better performance measures, and hopefully that leads to bonus incentive payments. It's also been shown to increase patient satisfaction, to lessen provider burnout, and to have a colleague that is really trained very differently from how diagnosticians are trained. So physicians, nurse practitioners, and physician's assistants are really trained to diagnose, whereas pharmacists are trained more in pharmacology for the treatment and management of the disease state. So some conversation starters, I try to include this in every single lesson just to give you some ideas about how to start having these conversations. Always, 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 you need to ask about what quality metrics or what benchmarks are they reporting on this year, or what HEDIS measures are they specifically focused on getting to goal in the upcoming year. So I like to say pharmacists solve medication issues, they reduce workload for providers, and they generate revenue. So again, the quality outcome example that I use, there's 4.5 million reasons at stake to get this right. So if you want to review back in the business blueprint, we talked about how to begin having these conversations using the 4 A's of selling. The first A would be assessing their pain points using a list of assessment questions, then asking for permission to share about your services, which Nikki Rouse did a fantastic training in February of 2020 about how to have that initial discovery call or initial discovery consultation, then agreeing on which terms would be most helpful, and acceptance and moving forward with your proposal. So again, these are some common pharmacist recommendations that I highly recommend you track as you are working with collaborative providers. These 5 things should always be a focus in your presentation to explain the value of pharmacist-led services and help you articulate your value. An embedded consultant pharmacists coordinating a comprehensive medication management program can drive every single one of these outcomes. And it's really all about a multidisciplinary approach. As we talked about in Lesson 10, integrating dietitians and nurses and PAs and pharmacists into the care plan is really how we focus on patient-centered care and patient-centered outcomes. It's most important, and the entire reason that I wanted to teach you about MACRA is so that you can describe your impact and articulate your value using the language of CMS, using the language so that you can have a seat at the healthcare table and be able to speak about the value of how pharmacists can help achieve these quality measures. So you need to be in the room when people are having these quality discussions. So identify potential collaborators in your area by starting with mutual patients. So reach out on behalf of patient care. Set up an appointment so that you can share with either the physician or the office manager or maybe even the care coordinator. Share some ideas that we've talked about here today about how a pharmacist can make an impact on providers' performance scores. Always remember, you can create these stories and case studies so that you can share when you've made an impact on a mutual patient, or you can even share stories about how other consultant pharmacists are having an impact on patients in their settings. So this could be a delivery service you offered, a medication synchronization program, a time you had a comprehensive medication review and caught a major drug issue, a time you were able to offer a point of care testing or screening service, and be able to be the bridge from the provider to the patient, because I think that pharmacies are very underutilized right now in the healthcare system, and I think it will be a growing trend to lean more heavily on pharmacy in the future to play a bigger role in the healthcare continuum. So first step would be establishing a relationship with a physician's quality manager or office manager. Maybe this is even a clinical nurse specialist. You can draft a cold call script. If you want some ideas for that, go check out the Business Blueprint course. Go check out Nikki Roush's January 2019 training for how to draft a cold call. You can run this idea by this person for how a consultant pharmacist might play a role in coordinating these care efforts and how you could benefit the clinic's bottom line and show good return on investment for their resources. I always recommend setting up a time to meet them in person. You can even call it a medication management needs assessment or a consultant pharmacist opportunity assessment, whatever you want to call it, but don't be afraid to reach out and ask for those appointments. So this in-person meeting, a good time could possibly be at 5 p.m. If you're wanting to speak with a physician themselves after the final patient of the day, or it could be a lunch and learn type meeting. Could be a good option so that you get face-to-face time with the physicians, but you can also be able to interact with his staff and talk a little bit about how you would make their lives easier. Remember, the focus of your presentation is not on you, it's on them. It's on their pain points. It's how you are going to help make their patient care experiences and make their jobs easier. You could create something like a medication management needs assessment, and really that starts with the assessment questions that you want to ask. So don't be afraid to ask for these in-person meetings, and if you need some support along the lines with what to say on these cold calls, check out the Nikki Roush's training for January 2019 in the forums. So be prepared to explain how your services, your existing services, or the future collaborative services you're pitching can help them meet their MIPS performance goals, meet their advanced APM benchmarks, or meet their HEDIS measures. So everything we discussed on Lesson 11, be able to speak to it and focus and align your services with the goals so that your main point is to help improve the quality of patient care and the provider's performance measures. Everything is about helping the provider. So use those 4 A's that we talk about in the business blueprint during that meeting. Focus on the ways you can streamline their workflow. Focus on ways that you can align your services with their quality metrics. Even make referrals super easy for them by creating templates and referral languages that they can upload in their EHR to help them identify high-risk patients that are outliers who could be affecting their quality measures. So again, providers have traditionally been resistant to diagnose people, specifically with non-adherence. There are 7 medication non-compliance diagnosis codes you could use when creating these referral templates. Those are Z codes listed here. But some main key takeaways I really want you to take away from this lesson is how understanding the quality payment system and understanding how value-based payment reform can give you insight into the motivations and the business models of the clinic. Always, always, always make sure that your services align with the goals of MACRA and helps them achieve their quality benchmarks. And seek out providers who may be interested in pharmacist involvement by connecting them through mutual patients and working out how chronic management, wellness screenings, and evidence-based guidelines can help them meet these patient outcome goals. Go ahead and request an appointment. Make these relationships and begin meeting people face to face to discuss the changes, to discuss their challenges, and to discuss their goals. Share your commitment to support them in this new performance-based landscape. They may not even understand as much about the quality payment program as you do now after watching this lecture. So CMS's overall objective is increase transparency and increase patient outcomes. They are trying to motivate providers to shift to this value-based payment program and shift away from the volume-based or fee-for-service. So those are the key takeaways from Lesson 11. I hope you feel a better understanding about what value-based payment system means. And if you have any questions, feel free to post your questions in the forums where we can continue to discuss the opportunities for your services to align with the goals of MACRA.